Welcome to Airway Breathing Conversation, a podcast presented by the Anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Sarah Foran, a PGY3 anesthesiology resident at the University of Saskatchewan in Saskatoon, discusses possible connections between cancer outcomes and choice of anesthetic technique. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Today, I'm going to be discussing, as Dr. B mentioned, the connection between our anesthetic agents that we utilize in the OR and cancer outcomes, specifically that of overall survival and recurrence-free survival. So in moving on to our objectives, today I'm going to be discussing the fundamental pathophysiological mechanisms by which our agents influence our immune system. I'm going to be discussing the findings from some of the published studies comparing the effects of volatile anesthetics and TIVA, as well as some of the studies published looking specifically at regional techniques and its effects potentially on cancer outcomes in human patients. And then I'm hoping from this presentation that it will allow you to have some tools in your kit to make informed patient-centered care decisions, while obviously recognizing the limitations of the published data. So moving on to why is this important? Well, this was a screenshot taken from the Canadian Cancer Society. As we all know, cancer is a major cause of morbidity and mortality worldwide. In Canada, researchers estimate there will be close to 250,000 new cases and close to 90,000 deaths secondary to cancer upon the completion of 2024. Surgery remains first line for solid organ tumors. However, recurrence and metastases following surgery do remain a major cause of both morbidity and mortality. Both surgery and the administration of our anesthetics trigger a complex physiological stress response that includes the activation of the sympathetic nervous system and the hypothalamic pituitary adrenal axis, both of which are integral to the body's stress response, as well as its inflammatory and immune processes. This period is characterized by a balanced release of pro-inflammatory and anti-inflammatory cytokines, as well as suppression of cellular immunity that can last for several days up to a week postoperatively due to the release of various neuroendocrine mediators, including catecholamines, prostaglandins, and glucocorticoids. During this period, there is a decrease in the number of circulating natural killer cells, cytotoxic T lymphocytes, dendritic cells, and T helper cells. This then represents a critical time in primary cancer surgery when inadvertently displaced tumor cells, which also can be referred to as minimal residual disease, which can be microscopic deposits at the surgical margins or micrometastases, can evade the immune system and become established metastases. Various factors then during this period can play a role in impacting the host defense mechanisms at a time when there is this vulnerability and generalized immune suppression, and can thus impact metastatic development. For example, minimally invasive surgeries or those performed laparoscopically have been found to be associated with reduced cancer recurrence risk, compared to open resections, while postoperative inflammatory complications, such as those like wound or pulmonary infections and anastomotic leaks, have also been found to further elevate that risk of cancer recurrence and reduce overall survival. What we still perhaps don't know a lot about is how our anesthetic agents impact this response and the risk of recurrence and overall survival following cancer surgery. And obviously, that's what I'm going to be focusing on in this presentation. And you might be wondering, well, the patient's coming in for surgery, we give them a couple of anesthetic agents, obviously, to get them through the procedure. What does it matter though in the long term? Like, why should we care? Well, the anesthetics that we use are obviously chemical agents, and they do have the potential to induce changes in epigenetic markers that can ultimately alter the stability and expression of information contained in human DNA. So the effect on epigenetics can occur even after relatively short exposures to our anesthetic agents, although it is more intense typically after prolonged or repeated exposures and can result in long-term consequences. For example, there have been studies that have examined the effects of these epigenetic modifications that occur perioperatively on outcomes that include postoperative cognitive dysfunction. And it has also been found that epigenetic alterations that occur in the perioperative period can play an important role as well in carcinogenesis. So there have been countless published in vitro studies that have looked at the role of anesthetic agents and the effects they have, both indirect and direct, on metastatic development. This occurs via several different mechanisms, and I'm going to really focus on two major mechanisms here in this presentation. The first is via cancer cell signaling. So I'm just going to briefly explain some of those terms that I have listed on the screen there. Hypoxia-inducible factors are a family of transcription factors that are ubiquitous in humans, and they govern the response to hypoxia, including angiogenesis and cell proliferation. It's an important, factor that all humans have. It's important for normal cells. However, cancer cells rely on these factors for their survival as they regulate various genes involved in critical aspects of tumor activity, such as cell proliferation, angiogenesis, glucose metabolism, and cell invasion. Similarly, overexpression of various growth factors, including insulin-like growth factor and vascular endothelial growth factor, have been noted in multiple different types of cancer and contribute to progression of cell cycle and inhibition of cellular apoptosis. Again, contributing to that potential tumor proliferation and metastases. Where this comes into play with our anesthetics is that multiple studies have shown that volatile anesthetics have typically a protective role against ischemia, reperfusion injury, and various organs. And typically, this is a good thing that we like to take advantage of. However, it is this exact feature that is associated with the upregulation of hypoxia-inducible factors in tumor cells and increased transcription of genes encoding these growth factors and others not listed here, thereby facilitating tumor growth, residual cell survival, and tumor cell migration in certain kinds of cancers. For example, laboratory studies of prostate and renal cancer cells have shown that isoflurane may enhance cancer cell growth via the modulation of the hypoxia-inducible factor signaling pathway, and that it increases this signaling pathway in proportion to its concentration and time of exposure. It should be noted that it does depend on what kind of cancer cell it is. For example, one study suggested that sevoflurane promoted metastatic potential and chemoresistance in renal carcinoma via an upregulation of this growth factor signaling pathway, but specifically found that it did not do the same in lung carcinoma. Propofol, on the other hand, has been found to have the opposite effect. It has been found to decrease these factors in a time and concentration dependent manner. It has been found to inhibit the upregulation of these hypoxia-inducible factors that occur with upregulation when exposed to volatiles. Specifically, it was shown that when exposed to volatiles in a study using prostate cancer cells, that propofol actually inhibited this overall upregulation, while a separate study found that propofol inhibited the invasive capabilities of non-small cell lung carcinoma cells, partly through the decreased expression of not only these hypoxia-inducible factors, but of these additional growth factors as well. So this is one of the main mechanisms through which our anesthetics have been shown in vitro studies to impact tumor cell growth and metastatic development. The second is via immunomodulation. So just kind of going over this briefly, the main cell or cell line that I want to draw your attention to is that on the right, the lymphoid stem cell, which goes into the lymphoblast, and then ultimately the lymphocytes and the natural killer cells. It is the natural killer cells, which are a type of cytotoxic lymphocyte that recognize and lyse tumor cells, and they are critical in the anti-tumor immune response. And multiple studies have shown that there is an inverse relationship between natural killer cell activity at the time of surgery and the development of metastatic disease. Animal studies have also shown that stress-induced reduction in natural killer cell activity can cause enhanced tumor development, while a higher incidence of cancer has been found to be associated with reduced level of natural killer cell activity in patients. So in terms of how our agents affect this type of cell, it has been found that our volatile anesthetics have been implicated with multiple studies reporting impaired immune cell number and function after exposure in various types of animal models of cancer. Specifically, sevoflurane has been found to suppress the activity of not only our natural killer cells, but they have also been found to induce T lymphocyte apoptosis and found to also increase the levels of pro-tumorigenic cytokines in multiple different types of surgery, including abdominal and breast cancer surgery. This is in contrast to propofol, which has been found to preserve natural killer cell and T cell function. A study by Buckley and colleagues in 2014 showed that serum from women with breast cancer undergoing surgical excision who were either randomized to receive a general anesthetic to receive a regional anesthetic plus propofol had greater human donor natural killer cell cytotoxicity in vitro compared with serum from women who received a general anesthetic with volatiles. So they had higher function and number of natural killer cells when they received propofol as compared to volatiles. Propofol has also been found in additional studies to preserve the relative cell ratios of our CD4 and CD8 T cells, as well as our helper 1 and helper T cells, as well as has been found to decrease the relative number of pro-inflammatory cytokines. So taken together, the in vitro studies have fairly consistently shown a beneficial effect with propofol and a possible pro-metastatic effect with volatiles. And I would say that that was quite consistent upon doing a literature search across various types of cancer cell lines. Moving on to in vivo studies. So these are 5 of the studies that I'm going to review in this presentation. All 5 studies were performed in humans. I'm going to go over 2 meta-analyses. I'm going to go over 1 very large retrospective study, as well as 2 randomized control trials. I'm not going to go over them in this order listed on the screen. Instead, I'm going to try to do it in the order that they were actually published in, just to try and give a bit of a timeline in terms of what the data has shown over the years. So going over the first study, which was a meta-analysis performed by Andrea Yap and colleagues in 2019 and published in the Canadian Journal of Anesthesia. They performed this meta-analysis to further analyze the effects of propofol versus volatile anesthesia on cancer recurrence and survival. They performed a wide database search from inception up until 2018, and they included comparative studies as well as RCTs examining this effect of volatiles versus TIVA on cancer outcomes. You can see here that close to 10,000 unique citations were screened, and ultimately 10 studies were included in this meta-analysis. All 9 retrospective studies did have a Newcastle-Ottawa scale score of over 7, which does demonstrate that there was good methodological quality and a low risk of bias. And the single prospective RCT included also had a low risk of bias for each domain that was measured. Five studies, 4 of the retrospective and the one RCT, examined this effect between TIVA and the volatile agents on recurrence-free survival, specifically in breast and esophageal cancer. The total sample size was just shy of 7,000 patients. When compared with volatile anesthesia, the use of TIVA was associated with what the authors report as a borderline protective effect, with an effect estimate of 0.79 and a p-value of 0.05. When looking at the overall survival, this included 8 studies, 7 of the retrospective and the 1 RCT, that included close to 20,000 patients with various types of cancer, including breast, colorectal, gastric, esophageal, and non-small cell lung cancer, and found that there was an associated improvement in overall survival with TIVA use when compared with volatile anesthesia. And they found that this effect was 0.76 with a p-value of less than 0.01. However, following this publication, there was noted to be some limitations of the study, including the predominantly retrospective nature of the included studies. Additionally, it's been noted that the studies included exhibited varying follow-up intervals and significant differences in some of the baseline patient demographics. There were some inconsistencies in the study characteristics, such as differing sample sizes across treatment groups. And some of the treatment groups were often imbalanced, with groups either in the receiving propofol or those receiving volatile anesthetics being much older or with significant comorbidities and with variations in cancer stages and grades. That was noted to be a significant limitation in the conclusions drawn. Additionally, there were differences in anesthetic techniques utilized. For example, several of the studies for patients that received propofol, some of them did or did not receive remifentanil at the same time. Additionally, in the volatile group, some received sevoflurane while others received desflurane, and there was not a way to perform, or the authors did not perform, a subgroup analysis to determine if the type of volatile agent actually played a role in these results. Going from there, on the heels of that meta-analysis performed in 2019, this large-scale retrospective study was performed in 2020 by Kaneko Makito and colleagues and published in the Journal of Anesthesiology. They conducted this large-scale study to compare overall survival and recurrence-free survival between volatile anesthetics and TIVA, utilizing a national inpatient database in Japan. The objective of the study was to evaluate this potential association of anesthetic techniques with cancer prognosis, specifically among patients having digestive cancer surgery. And they hypothesized that TIVA would be associated with a greater overall survival as well as recurrence-free survival than volatiles. So the authors selected patients who had had elective digestive cancer surgeries, and this included surgeries such as esophagectomies, gastrectomy, hepatectomy, cholecystectomy, pancreatectomy, colectomy, and rectal cancer surgery. So a wide array of surgeries from the years of 2010 to 2018. And ultimately, they identified close to 200,000 eligible patients, of which 166,000 patients were in the volatile anesthesia group, and just shy of 30,000 patients were in the propofol-based TIVA group. The groups were compared to ensure that they were relatively similar, and they did find that there was no significant differences with regards to many of the variables they looked at, with the exception of male sex, whether the procedure was performed at an academic hospital, year of surgery, and that was about it. So the groups were very similar. The median postoperative follow-up period was over 2 years in the volatile anesthesia group, and almost 3 years in the TIVA group. And you can see here, this is a Kaplan-Meier survival curve for overall survival at 1 year, which was found to be 89.8% in the volatile anesthesia group and 90% in the TIVA group. So ultimately, with this analysis, they found no significant difference in overall survival between the two groups. The 1 year recurrence-free survival was 80.8% in the volatile anesthesia group and 81.9% in the TIVA group. And again, did not find that there was a significant difference between the two. They also then performed a subgroup analysis, given that they had included patients undergoing multiple different kinds of surgery. And they ultimately found that there was no significant difference in overall survival or recurrence-free survival between volatile anesthesia or TIVA in any type of surgery performed that was included in this study. It was noted following the publication of this study that there was multiple strengths to be noted, mainly that this study currently represents one of the largest retrospective analyses investigating the impact of propofol-based anesthesia versus volatile-based anesthesia on oncological outcomes. The information included in the database was standardized, and the authors used a variety of strategies in their statistical analyses to limit confounding factors and biases. They also adjusted for multiple factors that are known to affect cancer progression and survival, including the administration of neoadjuvant and adjuvant therapies, perioperative blood transfusions, functional status, and postoperative complications. So overall, it was a very well done study, I would say. And that's kind of the consensus in the literature as well. And it's notable because previously, when some of the conflicting articles were coming out about whether propofol was beneficial in regards to cancer outcomes, it was thought that maybe it had a more pronounced effect in major surgeries. So the thought was that maybe if a patient is undergoing a larger, longer, more invasive procedure, that's where we would see the beneficial effect of propofol on these cancer outcomes really, shine. And this study then came out and has included surgeries that are quite invasive, including ones such as hepatectomies and esophagectomies. And this is shown, at least in this study, that this is not the case. Going on to the third of the 5 studies that I'm going to chat about, this second meta-analysis that was performed in 2021 was done by Chang and colleagues and published in the Journal of Anesthesia and Analgesia, again, to compare the effects of TIVA with volatiles on cancer outcomes, with a primary aim to look at overall and recurrence-free survival. Various databases were searched from inception through to 2020, and they included randomized control trials as well as observational studies that examined these 2 anesthesia maintenance techniques on long-term cancer outcomes. And ultimately, they ended up with 19 studies that they were able to include in their analysis. Of the 19 included studies, 17 reported on overall survival. And it showed that patients who received TIVA during cancer surgery were associated with a better overall survival than those who received volatiles. However, I should note that when they did a subsequent subgroup analysis comparing those who received propofol specifically with those who either received desflurane or sevoflurane, they found that this improvement did remain when they compared it specifically with desflurane, but they did not specifically find a difference in overall survival between those who received TIVA and those who received sevoflurane. So there was that specific difference between the type of volatile, and that did impact the results of this analysis. And then in looking at the recurrence-free survival, which included 10 reported studies, there was no statistically significant difference in recurrence-free survival between TIVA and volatile anesthetics. So we've discussed 2 of the meta-analyses as well as 1 large retrospective review. And next, we're going to discuss 2 of the more recent randomized control trials that have come out in the literature. This was performed by Mats Unland and colleagues in 2023, and they looked at the effect of propofol versus volatiles, specifically in breast cancer surgery, with the hypothesis that the propofol group would ultimately have an improvement in their 5-year survival. From just over 2,000 eligible breast cancer patients scheduled for primary curable invasive breast cancer surgery, 1,700 were recruited to this open label, single blind, randomized trial from 4 county and 3 university hospitals in Sweden and 1 Chinese university hospital. Some of the inclusion criteria included the fact that the patients had to be scheduled for elective, curable, and invasive surgery with general anesthesia with or without local infiltration, or regional anesthesia with a local anesthetic agent. And they could not be included if they were scheduled at any point for an emergency or palliative surgery. The study patients were randomly allocated to anesthesia maintenance with either propofol or sevoflurane in a 1-to-1 ratio. The 2 groups were comparable in baseline characteristics, except for a triple negative hormone receptor status. Regarding anesthesia-associated variables, differences were noted in the use of intraoperative opioids. Specifically, remifentanil was used more in conjunction with propofol, as one might anticipate. So 86.3% of patients in the propofol group did receive this opioid versus 42.1% in the sevoflurane group, while fentanyl was used more in combination with sevoflurane, and that was 69.5% of patients versus 24.4% in the propofol group. In all, 183 patients died during the entire observation period, with 10.8% occurring in the propofol group and 11.1% occurring in the sevoflurane group. Kaplan-Meier survival curves from the start of inclusion, almost 9 years earlier, to the end of follow-up did not indicate any difference in survival between the two groups, as can be seen here. It was noted when looking at some of the weaknesses within this study was that specifically with the volatile groups, there was a decision made not to record the dose of sevoflurane utilized for their anesthetics, and that decision was just made to simplify the procedure, or the protocol for the anesthesia staff, and cerebral monitoring was not mandatory. And so whether or not these groups were actually anesthetized to the same depth cannot be ascertained, although the authors mentioned that they had no reason to believe that they were not. And then this is the last randomized control trial I'm going to be chatting about with regards to this particular topic. And it was performed also in 2023 and published in the Journal of British Journal of Anesthesia. And they were testing the primary hypothesis that propofol-based anesthesia would improve survival over 3 or more years after potentially curative major cancer surgery. It was a long-term follow-up of a multi-center randomized controlled trial in 14 tertiary hospitals in China. So they recruited patients between 2015 and 2017, and just shy of 1,300 patients were enrolled in the underlying trial. They included subjects who were 65 to 90 years old, who were thought to have a primary, solid organ, non-neurologic cancer, who had not been previously treated with either radiation or chemotherapy, and were scheduled to have primary cancer surgery with a general anesthetic expected to last at least 2 hours. So the subjects were randomly assigned to either propofol-based anesthesia or a sevoflurane-based anesthetic. Ultimately, they included just shy of 1,200 subjects in the long-term follow-up analysis, with 598 subjects randomized to propofol anesthesia and 597 to sevoflurane. Among the subjects included in long-term follow-up, 97% of excised lesions were pathologically confirmed as cancer. And in terms of the differences between the two groups, the proportion of subjects with GI cancer was slightly lower, whereas the proportion with lung or esophageal cancer was slightly higher in patients assigned to propofol. It was also noted that the overall staging number was slightly higher in the propofol group. Overall, when they did their statistical analysis, again shown here via a Kaplan-Meier survival curve, they did not find any difference between overall survival between the two groups. There was 188 deaths among 598 subjects in the propofol group and 175 in the sevoflurane-based group. And they did not find that this resulted either in any statistically significant or clinically meaningful difference in recurrence-free or overall survival. So those are only two of the randomized controlled trials that have been published thus far. And it remains possible that a significant effect might be found in other cancers. But so far, the best available evidence is indicating that the choice between the two doesn't have a bearing on long-term cancer outcomes. Ongoing RCTs will add to this field, and there are a couple that are ongoing at the moment. There's one that's going to be completing their study in December of 2024, and that's the first study listed there. And there's two others that are currently in the midst of enrolling patients with an anticipated study date of 2028. So hopefully with some of those particular studies and the fact that they're looking at different types of cancers than those that have already been published about, we might get more data and information to help guide us as well. Switching gears just in this final part of the presentation, I also just wanted to touch on the role of regional and neuroaxial anesthesia and the connection that's been explored in the literature with relation to its role in long-term cancer outcomes. So available animal data does suggest that regional anesthesia and analgesia help to preserve effective defenses against tumor progression by attenuating the surgical stress response, by reducing general anesthesia requirements, and by sparing post-operative opioids. Those are kind of the three main mechanisms that have been postulated as to how this about how regional might decrease the risk of tumor progression. Specifically, just chatting about opioids and why this inhibition or reduction in opioid use might lead to an improvement in outcomes is because opioids inhibit both cellular and humoral immune function in humans, including antibody production, natural killer cell activity, cytokine secretion, lymphocyte proliferative responses to mitogens, and phagocytic activity. Furthermore, it's been found in studies that morphine is pro-angiogenic and actually has been found to promote breast tumor growth in rodents. Consequently, any sort of non-opioid analgesia, such as regional or neuroaxial techniques that helped to reduce our opioid use, is thought to preserve our natural killer cell function in animals and humans, and thus has actually been found to reduce metastatic spread of cancer in rodents. So several retrospective studies have examined how anesthetic methods might influence cancer recurrence after surgical removal across various cancer types. Regional anesthesia has been linked with lower recurrence rates and enhanced survival in cancers including breast, prostate, ovarian, melanoma, and localized colon cancer. Notably, there was a study performed that indicated that epidural performance and use during radical prostatectomies was associated with a 57% decrease in recurrence rates when adjusting for known prognostic factors. Other studies reveal comparable benefits within specific groups. For example, epidural use in colorectal cancer appears to lower recurrence rates, and findings suggest reduced all-cause mortality in patients undergoing rectal tumor resections. Likewise, local anesthetic use has shown advantages for melanoma excisions when the tumor was moderately advanced locally. But some analyses also found no benefit once other risk factors were excluded or identified effects that were not statistically significant. So the theory that regional anesthesia could reduce cancer recurrence initially originated from this extensive preclinical studies in both lab and animal models. And while early evidence from small retrospective human studies did indicate a possible link between regional anesthesia and reduced cancer recurrence, findings from later observational studies have been inconclusive thus far. And the study that I'm going to show you next, they chose to perform a systematic search of the databases from 1970 all the way through to 2023, using terms including regional anesthesia, cancer, surgery outcomes, and general anesthesia. So pretty broad terminology. They're trying to catch as many studies as possible. They ultimately identified 469 unique studies. The results were limited to RCTs, published in English, in which cancer recurrence was the primary outcome. And they excluded publications reporting secondary analysis of randomized controlled trials. And after examining abstracts, basically they were left with 4 RCTs that randomized a total of just under 5,000 patients for abdominal, lung, and breast cancer surgery. And what you can see here on the screen is a forest plot of adjusted hazard ratios for cancer-free survival across the 4 trials that compared regional anesthesia to general anesthesia and its effects on cancer recurrence. They utilized a random effects model, and unfortunately, they did not find a significant difference in cancer-free survival between regional and general anesthesia. So obviously, these results were unexpected based on the considerable in vitro and animal work, suggesting that regional anesthesia should reduce cancer recurrence after potentially curative cancer surgery. So it came as a little bit of a surprise. And so the authors did spend quite a bit of time in their study trying to look at the possible reasons for this disconnect. And they did come up with several potential reasons. Limitations of the relevant in vitro studies included the use of established cell lines rather than cancer cells derived directly from patients. There was also inadequate replication of tumor microenvironments and absence of 3-dimensional tumor structures and extracellular matrix, as well as the application of excessively high drug doses and prolonged exposures. This was some of the issues that they found with the in vitro studies that had been published on this topic. In terms of the animal studies utilized, they found that they employed a simplified approach to human tumorigenesis and metastases and involved tumors with genetic profiles that differ from naturally occurring ones. They also found that certain models, for example, in one type of model, it entails performing a tail vein injection of cancer cells into either the tails of mice or rats. This type of procedure fails to accurately replicate the behavior of natural tumors. And then finally, not from this study, but there was a commentary then published regarding this study, and they also brought up the fact that there was likely concern regarding publication bias and that this might be one of the reasons for the disconnect. So an analysis performed by Payton and colleagues found that when looking overall just at publication bias, just in the general literature, not necessarily related to this particular topic, they found that among more than 1,000 abstracts of clinical trials presented at the annual ASA meetings from 2001 to 2004, those with positive findings were more than twice as likely to proceed to eventual peer-reviewed journal publication compared to those with negative findings. Once the International Committee of Medical Journal Editors implemented mandatory prospective clinical trial registration for publication after 2005, they did repeat their analysis of ASA abstracts from 2010 to 2016, and they did find that the magnitude of imbalance in publication outcome had significantly reduced with an odds ratio of 1.3, but they note that mandatory prospective trial registration does not extend to preclinical trials and animal studies, nor to the publication policies of journals in other fields of biological sciences. So obviously this still remains quite a large issue and might be one of the reasons that we see this huge disconnect. And this begs the question as to whether this gap between preclinical research and our clinical trials could have been avoided. And unfortunately, there is no straightforward answer. Basic science methodologies evolve quickly, and our understanding of previous methodological limitations does continue to improve. However, organizing and conducting a series of clinical trials to investigate a theory can take a decade or longer. Therefore, clinical trials are often based on science that is at least partially outdated by the time they conclude. A key aim, though, of preclinical science is to inform trials, serving as that initial step toward rational clinical application. And therefore, the authors had postulated that it's reasonable to ask basic scientists to assist with this transition, as they are often better equipped than clinical researchers to assess which findings are most likely to be translatable, so that we can actually be performing clinical trials that we think will result in findings that can lead to updated practice guidelines and clinically significant, changes that can affect our patients for the better. So ultimately, in terms of conclusions, I think the studies remain mixed as to whether the anesthetic technique improves cancer outcomes or not. I think there's a growing body of evidence that it does not. If you were to take a look at the literature at first glance, as I was doing when I was getting ready for this presentation, I would say initially, I thought my presentation was going to suggest that propofol is better than volatiles for cancer surgery. And that's the way I was gearing my presentation to go. But as you delve more into the literature, I would say that you might find that this is true with many of the in vitro studies. And I would say the majority of the in vitro studies that I read does definitely support this. And you would find that propofol has all these, benefits and this magnitude of effects, as I had mentioned, on cancer cell signaling pathways and immunomodulation, that makes it appear as though it would have a potential beneficial effect in humans. But if you dig further into the human research aspect of it, and if you take a look at what's been published in terms of randomized control trials, I would say this has not been borne out in the literature. Of course, I've only presented a handful of studies, and there's many, many more out there. And the ones I presented, I think overall did not show any sort of huge benefit in terms of overall or recurrent-free survival. However, if you were to go through the literature yourself, you would definitely be able to find studies that support the opposite of this and do say that they actually have found a beneficial effect of propofol. And so I think while it is reasonable to suggest that the choice of anesthetic approach be guided beyond factors such as cancer recurrence, I still think that if you were to use that as one of your factors in your own approach, that you would have literature that would be able to back you up, and you would have studies that you could point to and say they had a benefit, like a beneficial effect seen. So I think it's more so just what studies you actually look at to help support your decision. I think just overall, in looking at some of the higher level evidence, including the systematic reviews and the RCTs, that it seems to be trending in the direction of there seems to be no beneficial effect.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.